dear representatives of the national patient associations and also general public who is interested in these issues of cirrhosis and the research that is done on liver patients. So we are very happy to welcome you to this online educational events for patients from the projects Decision, MicroPredict, and A-Tango project. And without further ado, I will just give the floor to Professor Yalan, who will chair this meeting with me. Professor Yalan.
Okay, so look, thank you very much, Marco and the ELPA team for organizing this. You know, we believe that cirrhosis is really where the biggest unmet needs are, and it is really a great pleasure for me to introduce you to my colleagues who will be talking for the most part after my introductory statements. So essentially, Pierre-Emmanuel Ratou, who's a professor of hepatology at in Paris, will be telling you about the exciting project which is called Decision, which is trying to find new treatments for cirrhosis. Professor Trebecker is a world leader in terms of understanding the relationship within the gut and the liver and how it impacts. And he is running probably the largest liver study funded by the EU. All these three projects are funded by the European Commission. And he'll be talking a little bit about what the importance of the gut is. Cornel Trebecker is really the world leader in terms of understanding the importance of the gut and liver disease. And he's leading the project called MicroPredict, which will define the role of the gut in liver disease. And very excited that Cornelius Engelmann, who's probably the youngest of the speakers today, is leading on a project called A-Tango. A-Tango, which is a combination of two drugs that he discovered while he was working here at UCL with us. And he's also won a big grant in order to bring this to man. So you'll hear three new approaches about problem solving in cirrhosis. I just want to put this out there to say that, you know, you've obviously done a lot of, you understand fatty liver disease and alcohol, but the news story today is really about cirrhosis. And this is a seriously under-resourced, unmet area. Just to give you highlight numbers, you know, 844 million people study with chronic liver disease, but of these, 2 million people die each year. And these are deaths that occur from cirrhosis. Just to put this number into context, 100 million people have cirrhosis. 10 million people have decompensated cirrhosis. And what is really frightening to us, it must be frightening to you as patients, representatives, is that mortality has remained unchanged for the last 30 years. Because the only treatment we have is liver transplantation, which is available to very few. So people are dying from cirrhosis, and we need to start to think about how we reduce these deaths. And just to give you an instance, that in the last 30 years, there are only 2 new drugs that have been discovered. And these are not new drugs. They've been repurposed. The first is rifaximin, which is an antibiotic. It can't be very good for you. Ocaliva is used for primary biliary cholangitis, costs $75,000 for a year and does not improve mortality. So we are working in an area with very few treatments. And this is, you know, big problem for us. So just to give you a number that when a patient, cirrhosis occurs after 20 to 30 years of injury. It can occur in patients with any cause of liver disease. Doesn't matter whether hepatitis C or B or alcohol or fat, they all culminate into cirrhosis. And when cirrhosis occurs after 20 to 30 years of injury, 50% of these patients will decompensate, develop one liver-related complication in 5 years. And once they develop this complication, 50% will die in the following 5 years. So the clock starts with cirrhosis. And at this present time, we have no treatments to prevent these complications. We have no treatments to prevent progression. So that's a massive unmet need, which we need to try and solve together. And Decision, A-Tango, MicroPredict are moving in the right direction, but we need more young people to help do the science and develop new therapies. So one such group that is addressing cirrhosis, and this is a couple of words about European Foundation for the Study of Chronic Liver Failure. This is an organization that I'm now the scientific director for, and all these projects are being coordinated by European Foundation of CLIF. And as you can see here, our mission is really to improve the lives of patients with cirrhosis, not only the quantity, but also the quality. That is a key metric. How are we going to do that? We're going to do that by partnering with the best hospitals in the world. We have 170 centers distributed around the world that are starting to study cirrhosis. We are very well distributed in gender matching. We are very collaborative, and with Marco and the ELPA team, we have started to build those collaboration that brings the patients in to tell their stories. This just gives you a little sense for the kind of studies we do. We have large number of participating hospitals. We recruit a large number of patients in our trials to give them the benefit from the drugs and devices that is being developed. We collect a lot of samples so we can study them to better understand the disease. And these are the different projects that are running in CLIF at the moment. The two new ones that are not on this slide yet is a project called CHANCE, which is focused on liver transplantation, and ETANGO, which you'll hear about today, which is focused on building this new drug for these patients. So I'm going to stop there, hand back to Marco to introduce the speakers, and we can take some questions at the end of each of these talks as we move forward. So thank you very much.
So thank you very much, Professor Yalan, for this really, really good introduction and scope of the activities that we do. From a patient side, we do understand that this is an extremely important issue. And I just want to stress one thing that is maybe not stressed enough. We are talking about ACLF. So we are talking about patients whose chances are really small, really relatively in a small range, what is there to do. So we do appreciate all the speakers that are here today with us, that are trying to change this landscape for the benefit of every patient who has faced liver disease, especially patients that are facing like ACLF or cirrhosis. So without further ado, I would really like to introduce our first speaker, Professor Pierre Emmanuel, who works in a project that is called Decision. And one thing, when we, prior to the start, it's a unique opportunity to see three big projects presented in one event. This is something that was never done before. And this is something that was proposed also by Professor Yalan when we were talking, and Amelie from company Concentris, we all recognize the importance of sharing, not sharing just nice words, but also sharing the focus, the everything that we need or want change for patients. So European Commission is keen to know what these projects will bring us, what will be the benefits for the patients. And I think we have three excellent speakers, or four excellent speakers, that will present these projects where ELPA was invited to join as a patient representative. So Professor Ionel Trebitschka, he's the leader of the project MicroPredict. He will speak about candidates, pathways, targets that will be important in the future, especially the gut-liver axis and microbiota. Professor Trebitschka, the floor is yours.
Thank you very much, Marco. Dear ladies and gentlemen, it's a great pleasure for me to be again in this session together with ELPA. We already had a session last year on MicroPredict, and I would like to show you a little bit again the vision of MicroPredict, also in the context of the other projects which are ongoing with coordination by European Foundation for Chronic Liver Failure. So MicroPredict is dedicated in better stratification of cirrhotic patients, especially due to the microbiome. And the question is, of course, why microbiome? And I would like to start, and also to get the connection to the talk of Pierre-Emmanuel, since you heard about all these complications that you see here in patients with liver cirrhosis and portal hypertension. They get infected, they have ascites, they have variceal bleeding and other complications, many different complications, which in the end, in addition to the portal hypertension, they lead to an increased systemic inflammation, which is the key for the development of acute decompensation and also organ failure. And the point is that the organs that fail are not only the liver, but there are also other organs. And this constitutes the so-called syndrome that you heard before, the acute on chronic liver failure, ACLF. And indeed, starting into the precipitating events, we can say that, okay, 40% of the events are bacterial infection and alcoholic hepatitis. Nevertheless, in 30 to 40% of the patients, we do not find a clear precipitant that leads to this decompensation. We cannot identify an event which occurs to the patients and leads to the development of organ dysfunction and organ failure. So the question is this the gut? And I would like to show you a very simple drawing. So we have the gut, which indeed in cirrhosis, the gut barrier is impaired due to different reasons. I don't want to go into that, but you have to know that we have a leaky gut. So the bacteria and bacterial components may trespass the gut barrier and they enter into the portal vein, into the portal circulation, which brings them to the diseased liver. And indeed, the diseased liver leads to is further impaired by this, let me say, tsunami of bacterial components and also bacteria, which on the other side produce a lot of inflammatory markers, which meeting to their receptors, they can lead to apoptosis, so to the cell death in hepatocytes, to inflammation due to activation of immune cells, and to further increase in fibrosis due to activation of hepatic stellate cells or further aggravation of fibrosis. And on the other side, they can spill over into the extrahepatic compartment. So after the liver, going to the other organs, and they can lead to failure of the other organs. So this is our hypothesis that the gut, and especially the microbiome in the gut, is connected very clearly to the acute decompensation of patients with cirrhosis. So in MicroPredict, we want to identify predictors and also the mechanisms which are associated with decompensation and also progression of ACLF and death, and especially connected with the microbiome, so with the bacteria in the and with all the organisms in the gut. We want to stratify better the patients according to the different treatments, similarly to Decision, where their fixed combinations will be explored. In MicroPredict, we will focus into 2 different treatments, which I will which I will explain in the following. And finally, we would like to have microbiome-based markers, which can be easily used into different tests. And this test should be useful for the patients in the end to stratify their care. So the microbiome, I told you in the beginning, translocates. So we have it here. It interacts in the lumen with different treatments that we give to the patients via oral treatments. Then it interacts with immune cells in the blood and interacts in the liver with different treatments. And there are 2 different treatments which already were highlighted by Pierre-Emmanuel Ratou, who are interacting with the microbiome. The first is rifaximin. This is a poorly resorbable antibiotic. So it is an antibiotic which stays here in the gut. Still, we know it helps the patients. Nevertheless, if we look into the studies that are there, then we will see that some patients may benefit from them. You see them on the right-hand side. So if you give rifaximin, you have less ascites complications, you have less hospital admissions, you have less variceal bleeding, less sepsis. And on the other side, there are patients who seems not to benefit from rifaximin. So these are also cirrhotic patients, but you don't see a difference in the portal pressure. So the portal hypertension stays high. You don't see a improvement of the cardiac output, and you don't see an improvement in the kidney failure, in the kidney function. So we don't know who are the patients who benefit from rifaximin. On the other side, also albumin. We have the very nice study, the ANSWER study, published 3 years ago, where the patients received albumin for a long time, for 18 months. And you see here that we have a decrease in risk of death in the patients. The patients who receive albumin, they have a better outcome, almost 80% survival after 18 months, while the patients who did not receive albumin, they have a very low survival. But we have also the study, the MATCH study. Here again, the patients received albumin. There were patients in the waitlist for liver transplantation, and you see here that these are the patients with albumin and also midodrine, another drug. Nevertheless, they have, you can say that they do not do better than the patients who received placebo. So we don't know who are the patients who will benefit from either rifaximin or from albumin. And we think that since the albumin also is excreted in the gut and may be measured, the effect of albumin also in the gut microbiome, we don't know who are the patients who will benefit, and we think that the microbiome-based biomarkers may help us in the certification of these patients. So what is our approach? We collect 12 microbiome initiatives in the field of hepatology with more than 10,000 patients and controls. We have already more than for more than 2,500 patients and 7,000 controls already omics data. So we have analyzed the microbiome, we have metabolomics, and also other things. And we are going to perform multi-omics analysis of more than 1,000 patients in our study. So this is the overview, a very busy slide. I don't want to go into detail. I would just like to show you that we have several studies which are useful and will be helped in the MicroPredict study to elaborate on the biomarkers. So we have a very complicated idea of all the data which we are going to analyze, and the novel data we are going to raise, and we are going to perform here to see key signatures and mechanisms which may help us to perform 3 different tests. The first test to predict the progression of ACLF and progression of patients with cirrhosis. The second test to predict the response to rifaximin. As I said, we need to show which are the patients who really benefit from this antibiotics, because in the end it is an antibiotic. And finally, we would like to see which are the patients who will benefit from albumin, because albumin is human and is costly, of course, and this is again another approach which may lead to an impact on the healthcare. So our vision is that we would like to have nanobiosensors, so point-of-care devices, just for you to as a help. We have the nanobiosensors everywhere. This is a pregnancy test, and something like that we would like to have, of course, not based on a single marker, but probably on a more complex biomarker composition of different markers, and probably due to or using a app or application in the mobile to read these results. So the idea is to perform a study using albumin. So at the moment, the patients who will come into the hospital, they may receive all albumin. Nevertheless, we have many hospitalizations due to decompensation, and we have a treatment, and we have a high degree of uncertainty of patients and relatives whether they will benefit or not benefit from albumin. We hope that after having this biomarker, we would like to show the patients, to treat the patients where we know that they will receive, they will benefit from albumin. They should also receive albumin, And the patients who will not receive or will not benefit from albumin, we should try to find other solutions for them. And this trial is a very complicated trial with 4 arms and so on, and will be headed by Professor Alexander Krag, who is also the coordinator of another Horizon 2020 project of the Project Galaxy. And indeed, this study will be performed in 7 different countries in Europe and in 9 centers in these countries. So the goal of the albumin trial, or of the ALB trial, this will be the first state-of-the-art clinical trial to aim to validate a microbiome-based biomarker, and this will be developed in this MicroPredict study. And this is our work package 7. After a lot of work in the last 2 years, and also probably also in the following year, this year, we hope to have a biomarker which we can use in the albumin trial, which will start hopefully by mid of next year. Of course, the short time for the biomarker development in a clinical setting will be the first in the liver disease. And this will allow us also to implement really personalized treatment guidelines and really to advise the clinicians, but also the patients, and to empower the patients who of them should receive albumin and who should not receive albumin. So what is albumin? Albumin is the most abundant protein in the human plasma, and it's usually produced in the liver. It is used as a product since in the 40s, and indeed it's also recommended for liver patients in very specific situation, large volume paracentesis. So if you have a lot of water in the abdominal cavity, and then if this water is released, an infection in the abdominal cavity, in this case, you should receive twice albumin. For renal failure in the so-called hepatorenal syndrome. And of course, the healthy volunteer plasma donors are normally the source of human albumin. It's safe and it's tolerable. Nevertheless, it is scarce, it is human, and it is not for everybody, and not everybody will benefit from albumin. So what about the albumin trial? We would like in the ALB trial to include 240 patients from 9 centers in 7 countries in Europe, the UK, Netherlands, Belgium, Spain, Germany, Hungary, and Denmark. And the study we will try to start it next year, and it will be completed in September 2024, hopefully. And all participants will regardless of liver disease, will participate regardless of liver disease, and the standard medical therapy will be compared to human albumin infusion every 7 to 10 days. And what is very special for this study is that this will be one of the studies which will be double-blinded, and it will be placebo-controlled. And the patients will receive it for 6 months. And during this study period, the patients will have repetitive intravenous human albumin or saline, which will be performed by research nurses who will also check on the participant well-being. And infusions every 7 to 10 days will be covered in black bags and also black lines. So it will be blinded to the patient, and it will be blinded to the healthcare personnel. Because what we don't want to see, we don't want to see our opinion in the results of the study. We want to see really who are the patients who benefit and whether our biomarker can separate these patients. So this is our vision, and this is my last slide, is that, of course, before MicroPredict, the patients had a long time with cirrhosis, but then when the decompensation started, then they will have repetitive readmissions, a lot of drugs receiving, and also a lot of healthcare resources will be used. And in the end, many of these patients will develop ACLF, and many of these patients will also unfortunately die because we can't do so much against that. Nevertheless, we hope that with MicroPredict, we can better stratify care, that we can early identify patients who may benefit, who will progress and also who may benefit from rifaximin or who may benefit from albumin, probably from rifaximin in the earlier stages to prevent decompensation, and with albumin after the first decompensation to prevent acute or chronic liver failure. And we hope that thereby we will better select and we will have a pool of patients where we can really help, and other patients where we are going to save them the unnecessary treatments. And this is our vision, and we hope that this approach will reduce mortality and will improve care of the patients and of course quality of life, because this is something which is very important. It's not so easy to measure, but I think it is very important for the patients and also for us, for healthcare professionals who take care of the patients. I would like to thank the MicroPredict team, who is so much involved in this study, and they had a lot of progress in the last 2 years, 2.5 years. Despite the COVID pandemic, we could keep on track on the most of our goals and deliverables and milestones, and this would not be possible without the support of the whole team. And thank you for your attention, and happy to take questions later on.